Onset, I must thank organizer for giving this opportunity for a separate hepatopathology session. So I can find there are a lot of people here, and I think we should continue it so that at least organizer will think about to give this in every year. Probably in the last year it is started. So now, as you will see, that there will be a lot of problem in this. Nowadays, we get two major areas from where the biopsies are usually the clinicians are asked for. And just to see one of them, already Dr. Bhanumati has mentioned the drug-induced liver injury. Another is this autoimmune liver diseases. And in fact, many times they are also confused with that whether it would be really a basic disease or it is following drug which patients are taking. Like if I go into the autoimmune liver disease, I will see that it's a group of disorder where the body really cannot recognize the self-antigen. And that is the thing. There are three main types. One is an idiopathic autoimmune hepatitis, primary biliary cholangitis, and primary sclerosing cholangitis. It is not true that the viral hepatitis is not immune mediated. In fact, there is no direct cytopathic effect of a virus. But in fact, most of the time, the immune cells destroy the hepatocytes which are infected with the virus. So that it's not a direct cytopathy unless it is an immunocompromised individual. So I'm not going into all these details which I've mentioned, and all of us know that there's a female predominance. But autoimmune hepatitis, idiopathic particularly autoimmune hepatitis, can occur in children, and in adults they are mainly females. So I'm not going into that, and it leads into cirrhosis, liver cancer, liver transplantation, and death. So any unresolving hepatitis with hypergammaglobulinemia and positive tissue-directed autoantibodies, one should really think about that we are dealing with a autoimmune hepatitis. Like, as I mentioned, that there is an aberrant autoreactivity by body to because of this molecular mimicry between viral and self-antigen. Now, as all of you know that very well, this is, I'm not going into details, and there are different type of autoimmune hepatitis. If you see this type 2 and type 3, they run a more aggressive course than the type 1. Now, this is the old this scoring systems. I'm not going into that. And this is the recent scoring systems. But what we have to be careful about, what is the compatible liver histology. Compatible liver histology for autoimmune hepatitis will be the significant inflammation, moderate to severe portal inflammation with a significant interface hepatitis, and nowadays this emperipolysis has come. But these two factors one has to take it to make it as this is compatible with a autoimmune hepatitis. Now then this combination of this autoimmune hepatitis with primary biliary cholangitis and primary sclerosing cholangitis, that will lead into this overlap syndromes. Now this is the one picture which I have taken from one clinical scenario. You could see there is significant portal inflammation. Mild portal inflammation without any definite history, without any significant interface hepatitis, is very difficult to make a diagnosis of idiopathic autoimmune hepatitis. So when you have a significant portal inflammation with like a complete interface hepatitis, one should think about autoimmune hepatitis. Now this type of extension of fibrosis making this rosating, this is also in favor of a autoimmune hepatitis. Very chronic viral hepatitis never produces like this. They produce mild to moderate inflammation, they produce mild interface hepatitis, but they never produce a significant interface hepatitis. Now this is the Masson's diagram which brings out this type of rosating much better, mainly in the periportal region. This will be the typical feature of a idiopathic autoimmune hepatitis. And another features which are usually we see, and we have to think this will come into the differential diagnosis of a drug-induced hepatitis, because this type of centrizonal hepatocytic necrosis, which is we always try to see, because in a casual look, I think we just cannot really make out this area. But when you do spatial stain like retic, where there is a condensation of reticulin, and if there is a more chronic, you can see some little bit of fibers, but the Masson's diagram brings out that centrizonal area with lot of fibrosis. This is also a feature of basically an acute onset autoimmune hepatitis or acute exacerbation in a typical autoimmune hepatitis. So now, I think there are too much stress on the plasma cells in autoimmune hepatitis. In fact, only 40% of the cases one sees plasma cells. And this type of plasma cell infiltrate in an otherwise clinically suitable, one can really make a diagnosis of autoimmune hepatitis. This is emperipolysis, I don't know. This is also too much stress nowadays probably. And this type of rosetting is more characteristics of autoimmune hepatitis rather than this emperipolysis. Now, just see the case scenario. You will find there is a 21-year-old female recurrent jaundice. Because of recurrent jaundice, always the clinical suspicion of a autoimmune hepatitis comes into picture. But benign recurrent intrahepatic cholestasis, of course, comes into the picture, but the viral markers are negative. But the SMA is isolated positive. But when you see this picture, there is a significant portal inflammation. I cannot trace out the boundary of this portal tract. That means there is significant interface hepatitis. And you could see this type of irregularity of the portal tract in the reticulin stain. And of course, if you see this plasma cell excess, then it will be very typical of a autoimmune hepatitis. Now, this is a case scenario 2. I think I'm going a little bit fast because it is only 15 minutes. So I think it is all right? Okay. Now, the case scenario 2, a 46-year-old male, jaundice for 2 months. And this is the one scenario where we always took out for a pathologist that could it be autoimmune hepatitis? Now, you just see the viral markers and autoimmune markers are negative. And history of CAM intake. This is very common nowadays. Whenever there is a prolonged jaundice, patient takes CAM intake. Now, you have to give an impression that whether it is fitting with the autoimmune hepatitis or not, because clinical impression was acute severe autoimmune hepatitis. Now you could see this is the lesion, and you could see that many areas there is no hepatocytes. So these are the areas of hepatocytic loss. Now you could see this is a devastating. When autoimmune hepatitis in acute severe autoimmune hepatitis or a acute exacerbation, there is a liver biopsy shows this type of effect. There hardly any normal liver tissue you could see. And you could see this on the periphery of this liver tissue, you could see this type of rosetting. And here there is a very significant portal inflammation. So when we see a significant portal inflammation with interface hepatitis, we should really think that it could be and it should be a autoimmune hepatitis. And you could see this many areas there are hepatocytic loss with laying down of collagen also. And this Mason spectrum brings out these fibrotic areas quite easily. And you could see this is some centrizonal area, and this is a periportal area. It is very, very irregular. And in some area, you could see this type of a hepatocytic loss around this centrizonal area. So all these points us towards that we are talking about the acute severe form of a acute onset autoimmune hepatitis. Now, here again, the recurrent jaundice in a lady and with a GGT normal, ceruloplasmin, 89.3 serum ferritinine, but the only one autoimmune marker which is really positive, that is the IgG 3500. But the rest of the autoimmune markers were negative. Based on this, in this type of scenario, we need to see. Now again, you could see the similar phenomenon. The whole liver biopsy shows significant inflammation, not just only in the portal and periportal area. And there are a lot of areas where this type of hepatocytic loss. And you could see this Mason spectrum in the centrizonal area. There is a lot of hepatocytic loss. And there is this periportal area where also you cannot see the boundary of the portal tract. That time really one should suspect that you probably were dealing with autoimmune hepatitis. And in fact, in any type of viral hepatitis, chronic viral hepatitis, we don't see this type of event. Now you could see this centrizonal area. There is this extravasation of RBCs and other things, all due to because of hepatocytic injury around the central zone. So this is a certain example of autoimmune hepatitis. Now if you see this other scenario where you will see mainly the centrizonal involvement, and there are a lot of this inflammation. There is significant lobular inflammation, and there are this type of plasma cells are there, and there are a lot of apoptotic hepatocytes, and you could see now the plasma cells. This will be all features of a autoimmune hepatitis. Probably it is a mode acute severe form of autoimmune hepatitis. And you could see this is the central vein and the portal tract area. In between there is extensive hepatocytic loss. All this points us towards autoimmune hepatitis. Now, what are the mimickers? Till now we have mentioned which are really very classical. Now, there is a 6-year-old girl with a serum AST ALT of 167 to 80 international unit, total bilirubin 1.8 milligram, and clinical impression was first was autoimmune hepatitis versus Wilson's disease. Now, this is probably the area. You could see this. It shows really a changes which are quite chronic. You could see one nodule here, and there are a lot of this hepatocytic areas of hepatocytic loss, and there is this extension of fibrosis and inflammation into the surrounding area. You could see that there are some are vacuolated hepatocytes, some are little bit more eosinophilics, and you could see these are the more, and you could see this area. This type of hepatocytes, what we call it as a, what do you call this one? Here, this type of change is also seen in it basically. You could see this, these two hepatocytic changes are different. And this type of changes are quite commonly seen in this condition. And in fact, this all showing features of a chronic liver disease like chronic hepatitis with nodule formation. You could see this area. And you could see this in the reticulin. There are extensive areas of hepatocytic loss. And there is this nodule formation. This is the areas where there is loss of hepatocytic loss. And this is the Mason's trichome brings out this nodule. But we can think about that it could be a very mimicker of autoimmune hepatitis unless you do a proper special stain. Now this is rhodanine, which brings out this extensive copper deposition in this nodule. And this deposition of this copper, this type of deposition is also quite patchy. And sometimes in case of this type of nodule, you could see, but in other areas, they are totally deficient in the copper. So this type of phenomenon can be mistaken as autoimmune hepatitis, but that's why the role of all special stains is mandatory in case of in the interpretation of liver biopsy. So this is essentially a Wilson's disease with almost in the cirrhotic stage at the 6 years of age. Now this is an example of Wilson's disease. Now I'll come into some other clinical scenario, and again there is the first episodes and then second episodes, whether again they are thinking of autoimmune hepatitis or a drug-induced. As there is a lot of discussion how a pathologist can make out that whether could it be a drug-induced hepatitis or not. But this is true because, as we mentioned, the drug has a direct cytopathic effect. On the other hand, immune-mediated injury, which most of the liver diseases are immune-mediated injury, they produce a much more inflammatory process as compared to drug-induced. This is a basic theme of it to identify. Like here, you could see that this is an area where there is a portal, there is inflammation, but they are not like a autoimmune hepatitis. And you could see even in this there are some occasional eosinophils. Whenever there is this type of a less inflammation, as compared to when you have to distinguish between a autoimmune hepatitis and a drug-induced autoimmune hepatitis, one should think about that this is probably a drug-induced injury. Like here you could see this type of eosinophils are also coming out. And again, secondly, this type of perivenular injury is also common in drug-induced liver disorder as compared to autoimmune hepatitis also. You could see this type of changes. Now you could see these eosinophils. And this is an example. You could see the centrizonal areas, again hepatocytic loss with this eosinophilic infiltrate. Now all this is again an injury with the centrizonal area, predominantly with a less inflammation in the portal tract area. That will qualify probably that one has to think about that this could be a drug-induced chronic liver injury. So now I'm just going into this type of area where there is a condensation of reticulin because of this centrizonal hepatocytic loss. And you could see this type of safety. This is the central vein we identify by these knobs. And here you can see this type of hepatocytic loss, which we really cannot appreciate mainly in the H&E section. That's why this role of reticulin is very great in it. So this is an example of a drug-induced liver injury. So I think there will be some query that when we really think about drug-induced liver injury, when we think that inflammation is much less as compared to the clinical parameter, then only we started thinking eosinophils may be seen, or even the neutrophils can help you make a diagnosis of a drug-induced liver injury. I think I should not go into this PSC, primary biliary cholangitis, and the primary sclerosing cholangitis. That will be in another chapter. So I will just stop it here. And if there's any questions, I can take it. So what is the basic conclusion based on this? That when we see a significant liver injury which are concentrated mainly around the portal tract, of course with a centrizonal area involvement, one should think about autoimmune hepatitis. When you have a clinical parameters is very much like a autoimmune hepatitis, but biopsy-wise you don't see that amount of inflammation, one should think about that this could be a drug-induced liver injury. So the basic theme of a diagnosis, distinguishing between drug and a liver and a autoimmune, should be the intensity of the inflammation that will make you to the diagnosis of a. So I can take up some questions because I cannot go into the other two. Yeah, that will be too extensive for.
Any questions from the audience?
Thank you for the lecture, sir. So we know that autoimmune hepatitis and NASH together as a recognized entity, ASLE says it's around 17 to 30%. So, but then coming to the revised score, it has a negative 3 point. If there is histological findings of other disease, it has a negative 3 point. So are we underdiagnosing autoimmune hepatitis in patients with NASH with AAH? That's my first question, sir. I have one more question. Can you enumerate the difference between compatible versus typical of autoimmune hepatitis? What do you call as typical? What is compatible?
Let's answer your second question. The typical features, histological features of hepatitis, autoimmune hepatitis, when there is a moderate to severe inflammation, not mild to moderate, and when there is a almost like a significant interface hepatitis with pericellular fibrosis. Significant means when you cross the periportal area, at least more than 50% of the boundary of the portal tract shows interface hepatitis. So in that situation, don't go into the presence of plasma cells and other things. That will be very, very, only in 40% of the cases you just see. Your first query is probably what you are thinking of a NASH with an autoantibody positivity. But I don't think we have a problem of diagnosing or excluding autoimmune hepatitis when I get a biopsy with a NASH with an autoantibody positivity. Most of the time, presence of this, again I mentioned the significant portal inflammations and the presence of a marked interface hepatitis, that will point us towards that we are dealing with a autoimmune hepatitis, not just a NASH or MASH with a antibody positivity.
Thank you, sir. One more question. Is there a histological difference between the seropositive and seronegative autoimmune, especially in the histology? Do you find any difference between these two?
Yes, there is no way you can distinguish seronegative and seropositive. There is in histology. Only thing which you can see this, is there an acute onset or acute exacerbation of a autoimmune hepatitis or a classical autoimmune hepatitis? You can make out because of this significant lobular inflammation and the centrizonal hepatocytic destruction, which you can say this could be an acute exacerbation of a previously diagnosed chronic autoimmune hepatitis or a acute onset autoimmune hepatitis.
There is a lot of gray zone between the drug-induced liver injury versus autoimmune hepatitis and drug-induced autoimmune hepatitis. So how will you differentiate between these three, or sometimes we are also confused?
I think this is a very, very difficult question by a pathologist also. As I again mentioned, if I get that I mentioned several times, I'm stressing on a significant or moderate to severe portal inflammation and a significant interface hepatitis will point us towards a usual idiopathic autoimmune hepatitis. On the other hand, if you see a drug-induced autoimmune hepatitis, this type of inflammation will be much less as compared to the idiopathic autoimmune hepatitis. And presence of neutrophils and eosinophils will point towards drug-induced autoimmune hepatitis.
We have the last question and a quick question.
So we find a lot of autoimmune hepatitis with mildly raised ALP and AMA positivity. So is there something, I mean, this ductopenia is not that common on biopsy, so how do we diagnose as a
this
overlap?
is you were talking about the problem of overlap syndrome. I was, but because of time, I couldn't go into. Ductopenia is a one thing, and when we add autoimmune hepatitis with a primary biliary cholangitis and primary sclerosing cholangitis, one has to see the periportal cholestasis. What do you mean by periportal cholestasis? Periportal cholestasis is nothing but a dilated dilated hepatocytes, and which shows when you do cytokeratin 7, they show cytokeratin 7 positivity. So bile duct, loss of bile duct, which we see in a very, very late stage, although that is the thing which we see in primary biliary cholangitis. So unless we see this type of changes like periportal metaplasia, biliary metaplasia, or a cholestasis, we don't call that as a, yes, some little bit of injury can occur because of this significant portal inflammation can attack some biliary epithelial cell. Most of the time they don't go, only 7% of the cases they show biliary duct injury. So unless we see these florid changes, we don't call it as a overlap syndrome.